Welcome to the deep dive. Today, we're unpacking a challenge that, well, often lands squarely on our plates in orthopedic practice, anterior shoulder instability. It's far more than just, a simple dislocated joint. It represents a really complex spectrum of conditions, and these can dramatically impact a patient's quality of life, particularly within our active populations.
Absolutely.
We're talking about quite a significant issue, actually, with a lifetime risk affecting anywhere from 1% to 2% of the general population. But what's truly striking, and what we frequently encounter, is its particular relevance to young, athletic individuals.
Yes, that demographic is key.
Imagine a scenario many of us have seen. A 17-year-old aspiring rugby player, let's call him Tom, crashes hard during a match, and suddenly his shoulder is out. He's in agony, the team physio reduces it, and now he's in your clinic, wanting answers. How do we ensure Tom gets back on the field safely and effectively without this becoming a career-ending issue?
That's the crucial question.
Yeah. So today, our mission is to embark on a deep dive into the evolving understanding of anterior shoulder instability, from its fundamental underlying mechanisms right through to the cutting-edge management strategies we employ to help patients like Tom.
Indeed. And what's truly fascinating here is precisely how our clinical understanding has matured, particularly over the last few decades.
Right.
We've really moved beyond those simpler, sort of more binary classifications to a far more nuanced and granular appreciation of the underlying pathology. And this shift is absolutely vital because it directly impacts how we approach and optimize patient management in practice, making sure we're not just treating a symptom, but addressing the root cause comprehensively. That's paramount for long-term joint health and function.
Okay, so to begin, at its core, what exactly defines anterior shoulder instability? And how do we differentiate it from other common shoulder complaints that present in our clinics, especially for a young, active patient like Tom?
Well, at its most fundamental level, anterior shoulder instability is defined as a soft tissue or perhaps a bony insult to the shoulder joint. This causes the humeral head, that's the ball of the upper arm bone, to either partially slip out, which we call subluxation.
You're right, subluxation.
Or completely dislocate from the glenoid fossa, which is the shallow socket of the shoulder blade.
Okay.
Now, both subluxation and complete dislocation, they manifest as pain and a sense of unsteadiness in the shoulder. And it's important to highlight that over 95% of all shoulder instability events occur in this anterior direction. So it really is our primary focus as orthopedic professionals.
95% anterior. Got it.
Historically, clinicians largely relied on two main acronyms to classify shoulder instability: TUBS and MBRI. You might remember those.
TUBS and MBRI.
Yes. TUBS stood for traumatic unilateral Bankart lesion and, crucially, required surgery. This typically described a discrete high-energy traumatic event, like Tom's rugby injury, leading to a single-direction instability, often with a specific labral tear, necessitating surgical intervention.
Okay, so that's the classic traumatic dislocation picture.
Exactly. On the other hand, MBRI referred to atraumatic, multidirectional, bilateral, responsive to rehabilitation, and if needed, an inferior capsular shift procedure.
Right.
This described patients who often presented with hyperlaxity, had instability in multiple directions, maybe in both shoulders, and where non-operative management was really the first line of defense.
Those sound like very neat, almost mutually exclusive categories. But I imagine clinical reality, especially with patients who push their bodies to the limit, is rarely quite that straightforward, is it? What was the critical flaw or maybe the aha moment that led us to recognize the need for a more refined approach beyond TUBS and MBRI?
You've hit on the precise point. While TUBS and MBRI were indeed historically helpful in guiding initial treatment, their primary limitation was their inability to effectively differentiate true instability, which is symptomatic abnormal motion, from soft tissue hyperlaxity, which is, an asymptomatic physiological translation. Think of it this way. Someone can have a lot of laxity in their joints, be double-jointed even, but it doesn't cause them pain or functional issues.
Right.
That's not instability.
Right, that's just how they're built.
Exactly. The acronyms also didn't adequately differentiate between acute high-energy macrotrauma, like Tom's, and the more insidious, recurrent, low-energy microtrauma that can lead to equally complex instability patterns. So this recognition really underscored the need for more granular classification criteria that directly inform our surgical decision-making.
So what are those modern criteria then? How do we classify it now?
So modern classification now emphasizes three more helpful criteria that guide us more precisely. Firstly, whether the instability is uniroki or multidirectional. Simple enough.
Okay.
Secondly, its origin traumatic or atraumatic. Traumatic cases typically present with unidirectional instability and an associated capsulolabral injury, as we might expect with Tom.
Mm-hmm.
Atraumatic cases, conversely, are often multidirectional and linked to generalized hyperlaxity.
Hmm.
And finally, we rigorously assess the presence or absence of accompanying soft tissue hyperlaxity. Now, this can be congenital, or perhaps a consequence of repeated microtrauma, a major single trauma, or multiple instability events.
I see.
This contemporary approach allows for a far more accurate characterization of each patient's unique instability pattern, which is crucial for predicting recurrence and ultimately planning the right treatment.
That's a very clear foundational understanding, especially distinguishing between that physiological laxity and true symptomatic instability. Now, if we connect this to the bigger picture, who is most susceptible to anterior shoulder instability? What do the numbers truly tell us about its prevalence and, maybe more importantly, its risk profile for our patients?
Well, if we look at the general population, studies dating back to the 1980s consistently showed incidence rates in the sort of low to mid-tens per 100,000 person years. This was across various populations, places like Minnesota, Denmark, Sweden. And a clear male predominance was established even back then.
Okay, so it's been recognized for a while.
Yes, it gave us a crucial baseline against which to track the condition's evolving epidemiology. More recently, a comprehensive UK population-based cohort study conducted over 2 decades from 1995 to 2015 provided more detailed statistics.
And what did that show?
This study found that a significant 72% of all shoulder dislocations occurred in men.
72%. Wow.
Yes, and interestingly, the highest incidence rate, at 80.5 per 100,000 person years, was observed in male patients aged 16 to 20 years.
Exactly Tom's demographic.
Precisely the demographic that Tom fits into. For females, the highest incidence rate shifted to an older age group, occurring in women aged 61 to 70 years. Overall, the male incidence rate stood at 40.4 per 100,000 person years.
Right.
And similarly, a 2010 study analyzing U.S. Census data from 2002 to 2006 reported an overall incidence of 23.9 per 100,000 person years, with the male incidence rate being approximately 2.6-fold higher than that of females.
These figures aren't just statistics. They paint a clear picture of who is most vulnerable. And crucially, where our preventative and early intervention efforts need to be hyper-focused. That sharp peak in young males isn't just a number, it's a fundamental shift in how we approach initial counseling, isn't it?
Absolutely. Those numbers certainly underscore the scale of the problem, especially in younger males like Tom. What about the athletic population, though? That's where we often see these injuries amplified, and the stakes for recurrence seem incredibly high.
Yes, the athletic population, particularly young athletes in high-impact or overhead sports, warrants significant attention due to their dramatically increased risk. A 2007 study, for example, prospectively tracked over 4,000 students at the United States Military Academy over 12 months. It revealed a 2.8% probability of a student sustaining at least one shoulder instability event during an academic year. Strikingly, over 85% of these events occurred in males, and 85% were subluxation episodes, with the remaining 15% being full dislocations.
So mostly subluxations in that group. That's interesting. It is. It indicates that even partial instability events are quite common in this high-demand group, and perhaps even more concerning, because they might not always get the acute attention of a full dislocation, potentially leading to chronic issues down the line.
Good point.
In contact sports, the figures become even more stark. A 2014 study on rugby players, for instance, reported a 15% prevalence of shoulder dislocation during a single season.
15% in one season?
Yes, and crucially, players with a history of previous shoulder dislocations managed non-operatively experienced a staggering 55% recurrence rate within that same season.
55% recurrent.
This is a critical takeaway for someone like Tom. The risk of redislocation, if not managed aggressively, is substantial. For American football, incidence rates can reach up to 0.51 per 1,000 athlete exposures.
Right.
Furthermore, a 2018 epidemiological study comparing high school and collegiate athletes across 9 different sports demonstrated that collegiate athletes are at a higher risk of shoulder dislocation, with an overall incidence rate of 2.04 per 100,000 athlete exposures.
So the higher the level, the higher the risk, generally.
It seems so. These numbers tell us that elite-level competition, by its very nature, pushes these athletes to a point where even seemingly minor biomechanical predispositions can lead to significant injury.
And what insights has the Multi-Center Orthopedic Outcomes Network Moon provided. They look specifically at patients undergoing stabilization procedures, don't they? Their data must offer a wealth of information for those of us making surgical decisions.
Yes. The Moon Instability Cohort's 2018 study offered some key demographic and injury insights that are very relevant to our practice. They found that a substantial 82% of the total 863 patients undergoing stabilization were male.
82% male, again reinforcing that.
Absolutely. Anterior dislocations constituted the majority of cases, accounting for about three-quarters in both male and female subgroups. Football and basketball were identified as the most common sports associated with these presentations, suggesting perhaps specific mechanisms of injury at play in those sports. Furthermore, their preoperative MRI findings revealed that anterior labral tears were present in two-thirds of cases, while Hill-Sachs lesions, which we'll discuss in more detail shortly, were noted in 41% of patients. So this points to a consistent pattern of soft tissue and bony pathology in surgical candidates.
Okay. And what about the younger end, adolescents and pediatric patients, say 10 to 16 years old?
Yes, when we focus specifically on that age group, a prognostic cohort study of nearly 2,000 patients revealed that the incidence of dislocation was highest among 16-year-old males at 164.4 episodes per 100,000 person years.
Again, right in Tom's age bracket.
Exactly. The lowest incidence was in the 10 to 12-year-old group. More concerning, perhaps, the redislocation rate was highest in the 14 to 16-year-old age bracket, ranging from 37% to 42%.
37 to 42% recurrence in 14, 16-year-olds. That's really high.
It underscores the significant challenge in this specific demographic, where growth plates might still be open and activity levels are incredibly high.
Those recurrence rates in younger patients are certainly alarming. So bringing it all together, what are the primary risk factors that jump out at you as critical predictors for these recurrent instability events? The things we, as orthopedic professionals, absolutely must look for during our assessment?
The key risk factors for recurrence are remarkably consistent across studies and should absolutely drive our clinical decision-making. They include young age, particularly under 20 years old, which is the most significant predictor, as we see with Tom.
Right.
Male gender, participation in contact sports, and the presence of underlying joint hyperlaxity or generalized hyperlaxity in other joints.
Okay.
Critically, osseous lesions, so bone loss on either the glenoid or the humeral head, such as a large Hill-Sachs lesion or significant glenoid bone loss, are also major contributors to a higher risk of recurrent instability.
So the bone really matters.
Absolutely. Missing these bony deficiencies is, frankly, a recipe for surgical failure. So when we assess a patient, we're not just looking at the initial injury, but systematically evaluating all these factors to gauge their individual risk of recurrence.
Right. Having understood the scale of the problem and who it affects most, let's zoom in now and really get to grips with the intricate biomechanics. What exactly is happening inside the joint that makes it so vulnerable to instability? Even for someone like Tom, who's otherwise incredibly fit and strong.
To truly grasp anterior shoulder instability, we have to appreciate the unique, almost paradoxical anatomy of the glenohumeral joint. It's a remarkably mobile, multi-axial ball and socket articulation, allowing for extensive motion, including 360 degrees of circumduction. It's incredible, really.
The most mobile joint in the body.
Exactly. However, this immense mobility comes at a cost. The glenoid fossa, the socket, is relatively shallow compared to the much larger humeral head, the ball. This inherent anatomical mismatch predisposes the shoulder to instability.
Like a golf ball on a tee.
That's the classic analogy, yes. It's stable, but easily knocked off. It's also important to remember that shoulder movements are coordinated across four distinct joints: the sternoclavicular, acromioclavicular, glenohumeral, and scapulothoracic joints, all working in concert. It's a complex system.
Okay, so how does the body compensate for that inherent instability? What are the stabilizers?
Well, the shoulder relies on both static and dynamic stabilizers. The static stabilizers provide inherent stability at rest and limit excessive translation. These include the bony glenohumeral articulation itself, the labrum, a fibrous cartilage rim that effectively deepens the socket by about 50%.
Quite the chalk block idea?
Exactly, often described as a chalk block or a bumper, and the glenohumeral ligaments, particularly the anterior and posterior bands of the inferior glenohumeral ligament, or IGHL.
The IGHL?
Yes. The IGHL is arguably the most critical static restraint, providing stability at different degrees of abduction and rotation. Other static elements include the rotator cuff interval structures and the negative intra-articular pressure, which creates a kind of suction effect, helping to pull the humeral head into the glenoid.
So the static elements are essentially the built-in structural safeguards. What about the dynamic stabilizers then? The ones that come into play when the arm is in motion? Like when Tom is reaching for a tackle on the rugby pitch?
Precisely. The dynamic stabilizers are crucial for maintaining stability during activity and for fine-tuning the glenohumeral articulation. This group primarily consists of the rotator cuff muscles, supraspinatus, infraspinatus, teres minor, and subscapularis, which dynamically compress the humeral head into the glenoid,
Okay.
along with the deltoid and the scapular and periscapular stabilizers. These muscles coordinate to maintain proper glenohumeral kinematics, effectively centering the humeral head within the glenoid during movement.
And the biceps, I've heard that plays a role too.
Yes, interestingly, studies have shown increased activity of the long head of the biceps in patients with recurrent dislocations, suggesting it may play some compensatory role in these cases. The shoulder instability cascade really describes how excessive humeral head translation, when these stabilizers fail for whatever reason, ultimately leads to pain, weakness, and dysfunction. It's often a progressive breakdown.
And you mentioned the distinction between laxity and instability earlier.
Yes, and it's absolutely critical for us as clinicians to distinguish between the two. Laxity refers to asymptomatic physiological translation of the humeral head on the glenoid. It's simply a normal variation in joint play, or perhaps even a compensatory adaptation in some elite athletes like swimmers or gymnasts. Instability, however, is a pathologic process where this abnormal motion becomes symptomatic, causing pain or a feeling of subluxation or dislocation. Pathological soft tissue laxity can stem from repetitive microtrauma, high-energy acute trauma, or even be congenitally present. But shoulder instability implies some degree of disruption to these static or dynamic stabilizers, whether it's the bony structures, the capsule, the labrum, or the glenohumeral ligaments. Understanding this distinction is fundamental to accurate diagnosis and appropriate treatment.
That distinction between laxity and symptomatic instability is key, and it really separates the truly injured from those with just a physiological variant. So, delving into the different types, how does the pathophysiology of unidirectional instability, the kind Tom likely experienced, typically manifest in terms of the underlying damage? What are we usually seeing?
Unidirectional instability often follows either a single acute high-energy traumatic event, as in Tom's case, or, less commonly, repetitive low-energy microtrauma, maybe in a throwing athlete. A significant point here is that when this type of instability occurs in a patient without underlying hyperlaxity, it's most commonly associated with a capsulolabral injury, a Bankart lesion, for example, where the anterior labrum is torn from the glenoid rim.
The classic Bankart lesion.
Yes. Conversely, if soft tissue hyperlaxity is present, an accompanying capsulolabral lesion is less likely to be the primary cause. The instability is often attributable to a patulous or overly stretched capsular tissue itself.
Ah, so the tissue itself is just too loose.
Exactly. Following a primary traumatic dislocation, it's also common to see at least a mild degree of chondral or osteochondral lesions, which is damage to the joint cartilage or underlying bone. Even minor ones are crucial to identify, as they can be silent drivers of long-term degenerative changes if not factored into management.
Right, and the bony defects, you mentioned they're significant contributors.
Yes, bony defects, whether on the humeral head or the glenoid side, or a combination of both, are now well established as significant contributors to the risk of recurrent instability events. Failing to identify and adequately address these bony deficiencies during stabilization procedures can lead to unacceptably high failure rates even after meticulous soft tissue repairs.
Okay.
This is why our imaging and surgical planning must be so precise. We have to look for the bone loss.
Ah, the Hill-Sachs lesion. This is something we hear about often, isn't it? Can you explain what it is and, crucially, why its presence and characteristics are so important in determining the prognosis and treatment for someone with anterior instability?
Absolutely. The Hill-Sachs lesion is an impaction injury. It happens to the posterosuperaortal humeral head. It occurs when the humeral head dislocates anteroinferiorly and forcefully abuts the anterior glenoid rim, creating a compression fracture, a dent, essentially, on the humeral head.
Okay, so it's a dent caused by the dislocation itself.
Precisely. And its incidence is remarkably high in anterior instability, ranging from 40% to nearly 100% of cases, with the highest rates observed in recurrent instability. So if Tom dislocates again, the likelihood of developing a Hill-Sachs lesion or worsening an existing one goes up significantly.
Right. And what's this about engaging versus non-engaging?
Yes, what's absolutely crucial to understand for clinical practice is whether a Hill-Sachs lesion is engaging or non-engaging. An engaging lesion is one where its long axis is parallel to the long axis of the anterior glenoid rim.
Okay.
This allows it to engage or sort of lock onto the rim when the shoulder is in the athletic position, typically 90 degrees of abduction and somewhere between 0 to 135 degrees of external rotation. That's often the position of tackle or throw.
This position of vulnerability.
Exactly. This engagement compromises functional stability and significantly increases the risk of recurrence. A non-engaging lesion, conversely, will not abut the glenoid rim in these positions, making it less clinically significant on its own.
That's a vital distinction. It completely changes the calculus for management, doesn't it?
Yeah.
I've also heard the on-track versus off-track concept used to explain this bipolar instability. Can you elaborate, perhaps using that tire and pothole analogy you mentioned earlier, to really clarify how the humeral and glenoid defects interact?
Certainly. The on-track versus off-track concept, introduced by Burkhardt and colleagues, provides an excellent way to conceptualize the relationship between the Hill-Sachs lesion and any glenoid bone loss.
Okay.
Imagine the glenoid articular tract, that is, the part of the glenoid that the humeral head normally articulates with through its range of motion, as the road or the tire track, if you like.
Right.
And the Hill-Sachs defect is a pothole on the humeral head, on the tire. A Hill-Sachs defect is considered off-track and will engage the glenoid if the size of the Hill-Sachs defect is greater than the available glenoid articular tract.
So the pothole is wider than the road allows.
Precisely. This is analogous to a tire falling into a pothole. The humeral head defect engages with the glenoid rim during functional movements, leading to instability. Conversely, an on-track Hill-Sachs defect means the size of the Hill-Sachs lesion is less than the glenoid articular tract, so it won't engage, like a tire smoothly passing over a minor imperfection in the road.
I see. So it stays on track.
Exactly. This concept is fundamental for guiding surgical management, as the goal is often to convert an off-track lesion into an on-track one to restore true functional stability. It means we're not just looking at each defect in isolation, but how they interact dynamically during movement.
Okay, that makes sense. Now, what about the other side of the equation, the glenoid-sided defects, the bony Bankart lesion? You said they're equally, if not more, significant.
Yes, absolutely. Glenoid-sided defects, specifically the bony Bankart lesion, are equally, if not more, significant and often the primary driver of recurrent instability, especially after failed surgery. Their prevalence can be up to 22% after an initial dislocation, skyrocketing to 25% to 90% in cases of recurrent instability. And perhaps most telling, they're present in a staggering 90% of patients who have undergone a failed primary stabilization procedure.
90% after failed surgery. That's huge.
It really highlights their importance, and this distinction between an acute bony Bankart fragment versus chronic attritional bone loss is often subtle on imaging, but is arguably the most critical differentiation for preventing surgical failure.
Why is understanding that erosion versus fracture so pivotal to your intraoperative decision-making? How does that change things?
It's pivotal because it dictates the entire surgical strategy, really. We distinguish between a true bony Bankart, which is an acute fracture fragment of the anterior glenoid rim, often quite sharp on imaging, and what we call attritional bone loss. Attritional bone loss results from chronic erosive changes, where the glenoid rim appears rounded off with blunted edges on imaging. It looks worn away. This is indicative of more chronic wear and tear process due to repeated instability events.
Right, the inverted pear glenoid.
Exactly. The most common location for these glenoid defects in anterior instability is often described between 2.3 and 4.2A on a clock phase, relative to the glenoid, so predominantly anterior-inferior. This attritional bone loss often presents as that inverted paraglenoid, where the inferior glenoid has lost its normal circular contour. Now, if the glenoid defect is significant, say, greater than 20-25% of its width, or even as low as 13.5% in some studies for high-risk patients like contact athletes, it indicates a high risk of failure for soft tissue repairs alone. Failure rates up to 89% have been reported in those cases. So if we see that significant attritional loss, we're looking at a different surgical solution altogether, usually bone augmentation.
So these ONI defects on the glenoid side can also arise from different mechanisms, not just acute fractures. And how does that mechanism inform your understanding of the injury? Does it change how you approach it?
Precisely. The pathological mechanism is often multifactorial. Acute low-energy compression fractures, perhaps from a direct fall onto the shoulder, can create a blunted osseous glenoid defect. But chronic attritional deficiencies develop over time, usually after an initial high-energy dislocation that included a glenoid injury, which was either managed non-operatively or perhaps failed surgical fixation. This leads to subsequent instability events and progressive erosion of the rim.
I see.
For instance, high-energy impact collisions, like those seen in rugby, can cause larger anterior glenoid rim fractures due to significant axial load being transmitted through the glenoid. In contrast, rotational forces, common in sports like American football perhaps, tend to result in smaller anterior glenoid rim avulsion injuries, as the inferior glenohumeral ligament literally pulls a fragment off during the dislocation. This distinction in mechanism often dictates the size and type of glenoid defect we see, which then profoundly influences the choice of surgical technique needed to restore stability.
This brings us to a specific manifestation: multidirectional instability, or MDI. You mentioned its definition has historically been debated. Can you shed some light on that and explain how its pathophysiology differs from the unidirectional cases we've been focusing on?
Yes, the definition of multidirectional instability has indeed been historically debated, which has contributed to some clinical ambiguity and made estimating its true prevalence quite elusive.
Yeah.
Neer and Foster originally described MDI as anterior and posterior instability combined with involuntary inferior subluxation or dislocation.
Okay.
Other experts have more broadly defined it as instability in at least 2 or 3 directions, so anterior, posterior, and/or inferior. The key distinguishing factor for MDI patients is its frequent association with generalized hyperlaxity, meaning they are often double-jointed and tend to report more frequent low-energy subluxation events, sometimes even occurring during sleep or with minimal activity like reaching for something.
So it's often linked to that underlying laxity.
Or very often, yes. When MDI presents without this generalized hyperlaxity, it's more likely to be accompanied by distinct anterior and posterior capsulabral injuries, making it a different clinical beast entirely, perhaps more akin to sequential traumatic events.
Okay, that makes sense. So we've covered the immediate effects and mechanisms of instability. What are the long-term implications for patients, particularly in terms of altered shoulder girdle biomechanics and the very real risk of developing arthropathy down the line? This seems crucial for long-term patient counseling, especially for a young athlete like Tom.
The long-term implications are profound and, frankly, often underestimated by patients initially. Firstly, glenoid bone loss significantly alters shoulder girdle biomechanics. When the glenoid loses bone, it decreases the available articular arc and creates a glenoid-humeral mismatch.
Right, less surface area.
Exactly. This reduced articular surface area means the glenoid cavity is less able to resist axial forces from the humeral head, leading to substantial shear forces being imparted to any repaired capsulabral interface.
Yep.
If glenoid bone loss is not properly addressed during surgical fixation, it significantly compromises the repair's long-term success, almost guaranteeing future problems like recurrence or wear.
Okay. And the scapula. You mentioned scapular dyskinesia.
Yes, additionally, alterations in static and dynamic scapular movements are highly prevalent, with scapular dyskinesia reportedly present in up to 80% of instability patients.
80%.
It's very common. This dyskinesia often involves excessive anterior tilting, internal rotation, and protraction of the scapula, along with decreased upward rotation during arm movement. This altered scapular posturing directly leads to excessive tensile and shear loads on the anterior band of the inferior glenohumeral ligament, AIGHL, further predisposing the shoulder to instability.
So it becomes a vicious cycle.
It really can be. Instability leads to altered mechanics, which then perpetuates further instability.
Right, and this leads to recurrence.
All these underlying pathophysiologic mechanisms, the bone loss, the altered mechanics, the ligamentous damage, can lead to recurrent instability, even after non-operative or operative management, if not perfectly addressed. Studies have shown that nearly 90% of contact athletes and up to 2/3 of non-contact athletes with significant glenoid bone loss will ultimately fail surgical stabilization if those bony defects, such as Bankart lesions or abnormal glenoid morphology, are not adequately addressed.
90% failure if the bone isn't addressed in contact athletes.
It highlights the critical importance of a comprehensive surgical plan that considers both soft tissue and bony pathology. Treating only the soft tissue in the face of significant bone loss is, simply put, setting the patient up for failure.
Okay. And the other big long-term concern is arthritis or dislocation arthropathy.
Yes, beyond recurrent instability, a serious long-term implication is dislocation arthropathy. Neer first described this back in 1982, defining it as the degenerative changes, essentially glenohumeral arthritis, that can develop in patients with a history of shoulder instability events or surgical stabilization procedures. What's particularly concerning, and perhaps counterintuitive initially, is that these arthritic changes can manifest even after a single dislocation. Samuelson and Prieta reported this in 1983.
Even just one dislocation.
Yes. This means that for Tom, even one significant dislocation could potentially set him on a path towards arthritis decades down the line, emphasizing the importance of getting the initial management absolutely right, aiming for perfect stability and restoration of anatomy.
So it's not just the cumulative effect of repeat dislocations causing wear and tear, but potentially the initial event itself that sets off a degenerative cascade. That's a powerful message for young patients, isn't it?
Precisely. While the exact role of recurrent dislocations versus the initial trauma isn't always perfectly clear, the pathophysiology likely involves acute changes that occurred during a primary traumatic instability event, cartilage damage, inflammation followed by a long-term predisposition to arthritis due to altered glenohumeral joint biomechanics, and perhaps progressive attritional osseous changes from any subsequent instability, even minor subluxations.
Right.
A prospective study by Havelius and Rom, which followed 257 primary anterior shoulder dislocations for 5 years, found that 27% of patients developed mild glenohumeral arthritis and a significant 34% developed moderate to severe arthrosis.
Wow, over a third moderate to severe after 25 years.
Yes, and this clearly indicates that even without multiple major recurrences, the joint can suffer substantial long-term degenerative changes. It's often a silent progression that we must proactively counsel our patients about, especially those with an initial high-energy traumatic event.
So understanding these underlying issues, the biomechanics, the crucial role of bone loss, the risk of long-term arthropathy is absolutely key. What's the practical, systematic approach for us as clinicians when assessing a patient like Tom for anterior shoulder instability? How do we piece together the history, the physical findings, and the imaging to get that clear picture and build our management strategy?
Well, a comprehensive history is absolutely paramount. It's our first and often most revealing diagnostic tool. For first-time dislocators like Tom, we need to gather really detailed information about the index injury. What was the degree of trauma? Was it high or low energy? What sports activity or position were they in? Was reduction required on field, in A&E, or did it necessitate sedation? This helps us discern a true dislocation from perhaps a subluxation and gives us clues about the potential for associated injuries. For instance, a high-energy traumatic dislocation is far more likely to cause significant labral or bony damage than a low-energy event.
Right. Makes sense.
For chronic cases, patients often present after a delay, maybe once range of motion limitations significantly impact their daily activities. We need to inquire carefully about any inciting instability events, as the initial injury might have been overlooked or downplayed years prior. Heightened suspicion is also warranted if there's a history of seizures, electrical shocks, or significant polytrauma where the shoulder injury could have been missed in the acute setting. For low-energy, recurrent subluxation cases, especially those occurring during sleep, it may indicate more complex instability, perhaps involving significant bone loss or an underlying capsular laxity problem. It's also vital to ask about medical comorbidities, family history of connective tissue disorders, or generalized hyperlaxity, as these profoundly influence prognosis and treatment choice.
Sure.
And of course, a thorough history includes occupational status, hand dominance, and any relevant surgical history to the shoulder or neck, as these provide context for their functional demands and prior interventions.
That's a very detailed patient history, uncovering not just the event, but potential underlying predispositions as well. Now, moving to the physical examination, what are the key pearls and provocative tests that help us zero in on anterior shoulder instability and distinguish it from other pathologies like neck problems or rotator cuff issues?
Right, the physical examination begins actually with a thorough C-spine and neck assessment. We have to rule out coexisting cervical radiculopathy, which can often mimic shoulder pathology.
Absolutely crucial first step.
It is. We look for neck posturing, muscular symmetry, palpable tenderness, and evaluate active and passive range of motion. Specific helpful tests include the Sperling maneuver, myopathic testing if indicated, reflex testing, and a comprehensive neurovascular exam to ensure no nerve root compression is contributing to their symptoms. It's a fundamental step that should never be skipped.
Okay, neck cleared, then onto the shoulder itself.
Yes, for the shoulder itself, observation is key. We compare both shoulder girdles for asymmetry, scapular posturing, muscle bulk, or atrophy. The deltoid often shows atrophy in chronic dislocators, perhaps indicating disuse or even axillary nerve involvement from a previous injury. In chronic anterior instability, you might palpate anterior fullness, with the posterior shoulder appearing relatively flat, almost a reverse contour compared to the normal side. We also assess scapulothoracic motion and look carefully for any scapular winging, as dyskinesia is so common in instability. Active and passive range of motion is documented, noting any limitations, especially in acute cases, or if we suspect significant bone loss. And crucially, we must diligently assess axillary nerve function, checking sensation over the regimental badge area and deltoid contraction, and motor sensory function of the elbow, wrist, and hand to rule out brachial plexus injury, along with distal pulses, especially after an acute reduction.
Neurovascular exam is vital.
Absolutely. For older patients, or if the history suggests it, special testing for concomitant pathologies like rotator cuff tears or biceps tendon issues is crucial, as these can certainly coexist, particularly after trauma.
And then come the provocative tests, the ones that really try to bring out the instability and differentiate it from other causes of shoulder pain. What are your go-to maneuvers there?
Indeed, the provocative tests are central to confirming instability and characterizing its direction and severity. First, we assess global tissue laxity. This involves examining hypermobility at other joints, often using criteria like the Baton score. A score greater than 4 suggests generalized hyperlaxity, often associated with MDI or connective tissue disorders.
Checking the Baton score.
Yes. We also look for shoulder-specific laxity, such as hyperexternal rotation of the side greater than 85 degrees or hyperabduction greater than 105 degrees, known as Gage's maneuver. Alternatively, a 2+ load shift test in 2 or more planes is indicative of significant capsular laxity.
Okay. And the apprehension test?
The anterior apprehension test is a cornerstone. It's performed with the patient's supine, shoulder at 90 degrees abduction and 90 degrees external rotation, applying a gentle anterior force to the humerus. A positive test reproduces the patient's instability symptoms, that specific feeling that the shoulder is about to come out, not just pain.
It's the apprehension that's key.
Exactly. And apprehension at lower abduction degrees, say 45 or 60 degrees, can strongly suggest significant glenoid bone loss, as less provocative positioning is needed to make the shoulder feel unstable.
Ah, that's a useful sign.
Following this, the Jobe relocation test involves applying a posteriorly directed force while the shoulder is in the same apprehensive position. Resolution of symptoms indicates a positive test, confirming the apprehension was due to instability, not just pain from another sort.
Right, the relocation confirms it.
Then there's the load and shift test. This is incredibly informative for assessing translation. It involves actually loading the elbow to center the humeral head, then applying anterior and posterior force at 0, 45, and 90 degrees of abduction, comparing to the other side.
And how is that graded?
Humeral head translation is graded. Grade 1 is just increased translation compared to the other side. Grade 2 is translation up to the glenoid rim but not over it. And grade 3 is translation over the glenoid rim, which might spontaneously reduce or need help. While this test has high specificity, up to 98%, its sensitivity for detecting uni- or multidirectional instability is actually quite poor, meaning a negative test doesn't reliably rule out instability. Patients can guard.
Right, and the Elsa sign?
The sulcus sign, performed with the arm relaxed to the side with an inferior pull, reveals a visible or palpable gap below the acromion. It indicates inferior instability and is a hallmark of MDI.
Okay.
And crucially, I must reiterate, in every patient undergoing surgery, an examination under anesthesia, EUA, should be performed and meticulously compared to the contralateral uninjured side. This allows us to fully understand the true degree of instability without any patient guarding, which can be very revealing.
That EUA is key for surgical planning then. That's a comprehensive clinical picture. But to truly unravel the problem and plan our intervention, imaging is indispensable, isn't it? What radiographic views are absolutely essential for a patient like Tom, and what advanced modalities do we rely on to fully quantify the damage, especially that critical bone loss?
Absolutely. Imaging is a critical component of the evaluation, especially for detecting bony pathology that the physical exam might miss or underestimate. For radiographs, a complete trauma series is essential. This absolutely must include a true AP or Grashy view.
The Grashy view, right?
Yes, which positions the patient 30 to 45 degrees offset from the cassette to get a true AP profile of the glenohumeral joint, avoiding overlap. We also require a scapular Y view, which is excellent for showing anterior or posterior displacement of the humeral head relative to the glenoid. And crucially, an axillary lateral view. Although this can be challenging to obtain in an acute traumatic setting due to pain, it gives the best view of the glenoid rim and any potential fractures.
Okay, Grashy, scapular Y, axillary lateral, the core 3.
Those are the essentials. These views help us identify obvious bony Bankart lesions, Hill-Sachs lesions, signs of glenoid erosion, and sometimes even HAGL lesions. humeral avulsion of the glenohumeral ligament, which might manifest as subtle medial neck scalloping on the AP view. Optional views like the West Point and Stryker views can provide more specific details on bony lesions if needed, but the core three are usually sufficient initially. It's paramount to get a complete series to avoid missing subtle dislocations, especially posterior ones that can be devastating if overlooked.
Right. And then moving beyond X-rays, MRI, CT.
For advanced imaging, MRI or MR arthrography is generally our preferred modality for visualizing soft tissue pathology. It's excellent for labral tears, assessing the capsule ligamentous complex, and looking at the rotator cuff.
Arthrography adds contrast.
Yes, the addition of intra-articular contrast in MR arthrography significantly increases both sensitivity and specificity for identifying these associated injuries, allowing us to see subtle tears or detachments that might be missed on a standard MRI. ABA sequences, that's abduction and external rotation positioning during the scan, are particularly useful for detailed assessment of the anteroinferior labrum and anterior capsule, as it puts stress on these structures, highlighting tears.
Okay.
MRI also allows for an accurate assessment of potential osseous glenohumeral defects or avulsions from either the glenoid or humeral sides, giving us a good qualitative sense of bone loss.
But for quantifying bone loss?
Yes, when it comes to quantifying bone loss accurately, CT imaging is considered the gold standard. While various quantification techniques exist, three-dimensional CT reconstruction techniques, especially end-face reconstructions of the glenoid with digital subtraction of the humeral head, are superior to simple two-dimensional measurements.
3D CT with subtraction.
Exactly. They provide easily reproducible quantification of glenoid morphology and are excellent at differentiating a true bony Bankart fracture fragment from chronic attritional bone loss, which appears rounded off with blunted edges. This distinction is vital because it directly impacts surgical planning. A true bony Bankart might be amenable to fixation, whereas significant attritional loss often necessitates bone augmentation, like a Latarjet procedure. We use these precise measurements to make informed decisions about whether a patient needs a simple soft tissue repair or something more complex.
That evaluation process sounds incredibly thorough, giving us a comprehensive roadmap of the injury. So once we have a clear diagnosis, especially for a young, active patient like Tom who wants to return to high-demand sports, what are the primary treatment pathways for anterior shoulder instability? And what factors truly guide the decision-making for our patients between non-operative and operative routes?
Well, the initial management of an acute shoulder instability event, if it's a dislocation, always begins with manual reduction, following radiographic confirmation of the dislocation.
Okay, get it back in place first.
Exactly. This is typically followed by a period of immobilization in a sling, usually for 1 to 2 weeks, though the exact timeline and position can be debated. Some advocate for external rotation bracing, but the evidence for its superiority in preventing recurrence is, well, mixed at best.
Right.
Cryotherapy ice is also applied for pain control and to reduce swelling. And crucially, return to play or demanding activities is avoided until a comprehensive assessment is completed, because we need to fully understand the extent of the damage before making any long-term decisions, especially regarding surgery.
Okay, so when is non-operative management a reasonable option?
For non-operative management, the indications are quite specific these days, particularly for young athletes. It's often considered for first-time dislocations with relatively minimal bone loss, specifically, glenoid defects less than perhaps 20–25%, and Hill-Sachs defects less than 25% that are definitively non-engaging on assessment.
So minimal bone loss is key.
Yes. It's also a path sometimes considered for non-contact or non-overhead athletes, or perhaps for athletes who wish to return in season and respond well to bracing, accepting a higher risk of recurrence. Physical therapy is, of course, the cornerstone of non-operative care. Following a brief immobilization period, patients are gradually weaned from the sling, progressing to full active and passive range of motion, and then strengthening exercises focusing on the dynamic glenohumeral and parascapular stabilizers, the rotator cuff, deltoid, scapular muscles.
Okay.
Sport-specific drills are introduced when strength and ROM are comparable to the uninjured side, and bracing can be considered for competition. While return to play is often contemplated after 2 to 3 weeks, studies consistently show that military personnel and overhead contact athletes like Tom tend to have unacceptably high recurrence rates with non-operative management alone after a traumatic dislocation.
So for Tom, non-ops might be setting him up for failure.
For a young contact athlete like Tom, the risk of recurrence with non-op management is often quoted as high as 80–90%. So yes, aggressive non-operative treatment in that scenario might indeed be setting him up for failure and further damage down the line. Activity modification and NSAIDs also help manage pain and swelling during this period, of course.
That makes sense. For those cases where non-operative management isn't sufficient, or for patients with specific risk factors like Tom, when does surgical management become the unequivocal recommended path? What are the absolute indications that tell you this patient needs surgery and they probably need it sooner rather than later?
Surgical management is clearly indicated for recurrent dislocation or subluxation after a trial of non-operative management has failed. That's straightforward.
Right.
But more importantly, for first-time dislocators who are young, typically under 20 or perhaps 25 years old, like Tom, or are overhead-throwing athletes or participate in contact sports, surgical intervention is now often the preferred primary treatment due to their extremely high recurrence risk if managed non-operatively.
So even after the first time for these high-risk groups?
Yeah, often, yes. The conversation definitely needs to be had. Surgery is also strongly considered if significant associated injuries are present, such as rotator cuff tears greater than 50%, though this is more common in older patients. Large bony Bankart lesions with glenoid defects exceeding 20-25%, or engaging Hill-Sachs lesions larger than 25%.
Okay.
Irreducible dislocations, where you can't get the shoulder back in, or associated proximal humerus fractures requiring surgery are also clear indications. Other relative indications include an inability to tolerate bracing, inability to return to baseline performance in their sport or occupation, or simply patient preference, especially if they're near the end of the season or in the off-season and want a definitive fix.
Right.
For Tom, given his age, his sport, rugby, and the likely high-energy nature of his injury, even a first-time dislocation points very strongly towards surgical intervention to minimize recurrence and potential long-term joint damage.
So once surgery is decided upon, what's the current thinking on open versus arthroscopic repair techniques? Have trends shifted significantly in recent years, and what are the specific advantages of each approach now?
There's been a dramatic shift over the last couple of decades. While open Bankart repairs historically offered excellent results with low recurrence rates and were once the undisputed gold standard, arthroscopic procedures have now become the dominant approach for most instability cases without significant bone loss. Studies from 2008 to 2012 showed arthroscopic stabilizations being performed at a rate greater than 90% in some regions, and those rates have likely only increased.
Why the shift to arthroscopy? What are the benefits?
The advantages of arthroscopy are compelling. Generally, there's decreased loss of motion compared to some older open techniques, potentially reduced morbidity, avoidance of subscapularis tenotomy, cutting the subscapularis tendon, which was part of the traditional open approach, and the critical ability to thoroughly visualize and address concomitant intra-articular pathology like small cartilage lesions or posterior labral tears that might not be easily visible or accessible with an open approach. Okay. Studies have also demonstrated a potentially faster return to preoperative muscle strength. Furthermore, arthroscopy acts as a dynamic diagnostic tool. Intraoperatively, you can probe the tissues, assess the extent of damage, and dynamically test the stability after repair, identifying any osseous lesions or areas of capsular redundancy that might compromise stability if only a standard soft tissue repair were performed. Yeah. It allows for an immediate intraoperative assessment of how well the repair holds under stress.
So arthroscopy offers diagnostic and potentially recovery advantages. Now, let's detail some specific surgical techniques for anterior dislocation, starting with the workhorse, the arthroscopic Bankart repair. What's the goal there?
The arthroscopic Bankart repair aims to repair and relocate the detached capsulabral complex back to its anatomic position on the glenoid rim. Specifically, it focuses on restoring the static restraining capability of the anterior band of the inferior glenohumeral ligament, AIGHL, which is often torn off with the labrum.
Okay.
The technique typically involves using suture anchors, small implants drilled into the bone with sutures attached to reattach the labrum securely back to the glenoid.
Yeah.
It often also includes capsular vacation, which means taking strategic stitches in the stretched-out joint capsule to tighten it up. This is particularly crucial in chronic cases where the capsule has become pathologically lax.
So repair the labrum and tighten the capsule.
Essentially, yes. However, it's important to note that outcomes for arthroscopic Bankart repair alone can be less favorable in patients with significant global hyperlaxity, significant glenoid bone loss, that 20-25% threshold, or if too few fixation points are used, using fewer than, say, 4 anchors, for example, is a known risk factor for failure.
Right.
So for Tom, if he has minimal bone loss on his scans and a discrete labral tear, this could be a very strong contender.
That makes sense. But what about when there is significant bone loss, either on the glenoid or the humeral side? That must dramatically complicate things and require entirely different strategies than a simple labral repair, as you mentioned.
Indeed, significant bone loss is a game changer, and failing to address it is probably the primary reason for surgical failure after instability surgery. For glenoid defects exceeding that critical 20-25% of the inferior glenoid width, or perhaps even 13.5% in some studies for high-risk contact athletes, or with large engaging Hill-Sachs lesions, augmentation procedures become critical.
Augmentation meaning adding bone.
Yes, or transferring bone. The Latarjet procedure, for instance, is the most commonly performed open bony augmentation procedure for anterior glenoid bone loss. It involves transferring a piece of the coracoid process, a bony prominence nearby with its attached tendons, down to the deficient anterior scapular neck.
The Latarjet. Okay.
This procedure has a remarkable triple effect. First, it acts as a bony block, physically increasing the width of the glenoid tract, making it harder for the humeral head to slip off.
Okay. Bony block.
Second, it provides a dynamic sling effect from the conjoined tendon transferred with the bone, which sits on top of the subscapularis muscle, dynamically compressing the humeral head posteriorly during external rotation.
Sling effect.
And third, it contributes to capsule reconstruction via the coracoacromial ligament, which is often transferred with the graft.
Triple effect. Right.
Right.
And the outcomes.
Outcomes are generally excellent. Recurrence rates with Latarjet are very low, typically ranging from 0.8%, with good to excellent functional outcomes reported in over 90% of patients, making it highly effective for significant bone loss scenarios.
Okay. What about even bigger glenoid defects or Hill-Sachs lesions?
For even more severe anterior glenoid loss, say over 40%, the Eden-Hibonette procedure, which uses an iliac crest autograft, bone taken from the patient's pelvis, can be considered, though it's less commonly performed than the Latarjet. And on the humeral side, for large, engaging, or off-track Hill-Sachs lesions, the remplissage procedure is often employed, frequently in conjunction with an arthroscopic Bankart repair. Remplissage means to fill in French.
Remplissage. Okay. How does that work?
This technique involves arthroscopically suturing the posterior capsule and the underlying infraspinatus tendon down into the Hill-Sachs defect on the back of the humeral head. This effectively fills the defect and tethers the infraspinatus into it, converting an off-track engaging lesion into an on-track non-engaging one by preventing it from contacting the glenoid rim during external rotation.
Oh, it stops it engaging.
Precisely. And studies show this significantly improves results, with recurrence rates as low as 5% compared to Bankart repair alone for patients with large engaging Hill-Sachs defects. For very large Hill-Sachs defects, perhaps exceeding 40% of the articular surface, sometimes actual bone graft reconstruction using autograft or allograft may be necessary, but that's rarer. These procedures are all about restoring the natural anatomy and biomechanics that have been compromised by the bone loss.
It sounds like there's a highly specific algorithm to guide these complex decisions, ensuring we match the right surgery to the right combination of bony pathologies. Can you walk us through Burkhart's algorithmic approach for choosing the right surgical technique based on the interplay of glenoid and Hill-Sachs lesions? That sounds crucial for standardizing care.
Yes. Burkhart and colleagues back in 2014 proposed a critical algorithmic approach that categorizes shoulder instability cases into 4 groups based on the presence and significance of glenoid and humeral bone loss. This framework is widely used because it logically links specific pathologies to proven surgical solutions, helping guide that complex decision-making process.
Okay, group 1.
Group 1 patients have minimal glenoid defects, less than 25%, and a Hill-Sachs lesion that is either on track or non-engaging. For these patients, a standard arthroscopic Bankart repair is the recommended technique. The soft tissue repair is likely sufficient to restore stability without needing to address minor bony defects. This is the most common scenario for primary surgery.
Right, Bankart alone for minimal bone loss. Group 2.
Group 2 patients also have minimal glenoid defects, less than 25%, but their Hill-Sachs lesion is off-track or engaging, meaning it will cause instability in the athletic position despite a good labral repair. In these instances, the recommended technique is an arthroscopic Bankart repair augmented with a remplissage procedure to address that engaging humeral defect.
Bankart plus remplissage for the off-track Hill-Sachs. Makes sense. Group 3.
Moving to Group 3, these patients present with more significant glenoid bone loss, specifically greater than 25%, but their Hill-Sachs lesion remains on track or non-engaging. For this group, the Latarjet procedure, or similar glenoid augmentation, is the preferred surgical approach. A soft tissue repair alone would be insufficient given the substantial glenoid deficiency. The Latarjet provides that critical bony block to effectively extend the glenoid tract.
So Letarjet for significant glenoid loss, even if the Ill-Sachs is okay. And group 4.
Finally, Group 4 represents the most complex scenario. Significant glenoid bone loss greater than 25% and an off-track or engaging Hill-Sachs lesion. This is bipolar bone loss. Here, the Letarjet procedure, or other glenoid augmentation, is generally performed first. The critical order is usually to address the glenoid deficiency first, as it's the primary stabilizer.
Okay, glenoid first.
Yes. Then, if, after the glenoid augmentation, the Hill-Sachs lesion is still determined to be potentially engaging or off-track relative to the newly augmented glenoid track, then additional humeral-sided procedures like bone grafting or potentially a rumplissage might still be recommended, though often the Letarjet alone addresses the bipolar issue. This algorithm provides a structured pathway to achieve optimal stability by addressing both sides of the bipolar bone loss when necessary. For a patient like Tom, if his injury were more severe involving significant bone loss, this algorithm would be our immediate guide for planning.
That's a highly sophisticated yet beautifully logical approach to surgical planning. What about multidirectional instability, MDI? Are the surgical strategies different for that? And maybe briefly touch on any historical procedures we should be aware of, even if they're rarely used now.
Yes, for multidirectional instability, the approach is different. Surgery is often deferred until the patient experiences significant morbidity and has failed a prolonged, dedicated course of physical therapy, focusing heavily on rotator cuff and scapular rehabilitation, often 6 months or more.
So rehab first is key for MDI.
Absolutely. When surgery is necessary, the primary goal is to address the generalized capsular laxity, typically by removing or tightening the redundant inferior capsule and often closing the rotator cuff interval, which can be abnormally wide or patulous in MDI patients.
Okay.
Neer's original anterior capsular shift procedure, often performed via an open delta pectoral approach, was common for MDI cases that were predominantly anteriorly oriented. This involved a T-shaped incision over the capsule to allow for precise tightening by overlapping the inferior and superior flaps. We're essentially shrinking the capsule to restore tension. Newer techniques are now often performed arthroscopically, allowing for perhaps more comprehensive 360-degree capsular plication or tightening.
Right, often arthroscopic now. And historical procedures.
As for historical procedures, they include techniques like the Putty-Platt, Magnuson stack, and Boyd-Sisk. These procedures primarily aim to tighten the subscapularis muscle and anterior capsule very aggressively to limit external rotation. However, they are rarely indicated now because they often led to significant overconstraint of the joint. This resulted in a major loss of external rotation and, unfortunately, a relatively high rate of post-capsulorrhaphy arthropathy, early onset osteoarthritis, particularly with posterior glenoid wear, due to the humeral head being chronically pushed posteriorly by the over-tightened anterior structures.
So they caused arthritis.
They could, yes.
Yeah.
It's a good reminder of how our understanding and techniques have evolved to favor more anatomical, balanced repairs that aim to preserve motion while restoring stability, rather than just locking things down.
That's a thorough overview of the surgical landscape. But the journey certainly doesn't end in the operating theater, does it? What does the critical postoperative recovery and rehabilitation look like after these procedures? And what are the long-term expectations and potential challenges patients need to be aware of?
Absolutely not. Postoperative care and dedicated rehabilitation are paramount for successful outcomes and preventing recurrence. Following surgical stabilization, the patient is typically kept immobilized in a sling for an initial period. This usually lasts 4 to 6 weeks, though it can vary based on surgeon preference, the complexity of the instability, the type of repair. For example, a Letarjet might be immobilized differently to a Bankart, and the perceived robustness of the fixation achieved.
4 to 6 weeks in a sling, generally.
Generally, yes. During sling use, we encourage early active range of motion for the elbow, wrist, and fingers right away to prevent stiffness in the discal joints.
Okay.
Once immobilization ends, passive and then active assisted and active shoulder range of motion exercises are initiated, guided by the therapist. We carefully avoid extreme provocative positions, specifically combine shoulder abduction and external rotation for approximately 8 weeks post-surgery, sometimes longer depending on the procedure, to protect the healing repair. Our goal is usually to achieve full active range of motion by the 8 to 12-week mark in most straightforward cases. Progressive resistance and gradual strengthening programs typically commence around 10 to 12 weeks post-operatively, again, guided by the therapist and the surgeon's protocol. These focus heavily on the dynamic glenohumeral and periscapular stabilizers. The rotator cuff, deltoid, and scapular muscles need to be retrained and strengthened to support the static repair.
Okay, strengthening starts around 3 months. And for athletes like Tom, the critical question is always, when can I get back to my sport? How do you manage those expectations and set realistic timelines for return to play? That must be a constant conversation.
It is, and it's a vital consideration where personalized counseling is essential. Return to sport-specific drills, practice, and ultimately competition will vary significantly based on many factors: the athlete's specific position, the demands of their sport, contact versus non-contact, overhead versus non-overhead, their performance level, the complexity of their initial injury, the type of surgical repair performed, and their progress in rehab.
Lots of variables.
Absolutely. Generally, a return to sport is advised no earlier than 3 months post-surgery, even for less demanding activities. For high-impact collision sports like rugby or American football, this timeline typically extends to around the 6-month postoperative mark, and sometimes longer, perhaps 9 months or even a year for certain procedures or positions, like throwing athletes.
6 months minimum for contact sports.
As a general rule of thumb, yes. We really need to see full, pain-free range of motion, strength comparable to the uninjured side, often checked with isokinetic testing, restored proprioception and neuromuscular control, and successful completion of sport-specific drills before giving the green light for unrestricted return to play. Return to work also varies, with a mean time of about 2 months reported for arthroscopic Bankart repair, though this can range widely from as early as 1 week for desk jobs to up to 10 months for highly demanding manual labor occupations.
Okay. And what about prognosis? How accurately can we predict recurrence rates now? You mentioned the ISIS score earlier.
Yes, the prognosis and recurrence rates are highly dependent on those factors we discussed: age, type of sport, presence of hyperlaxity, and crucially, the existence and treatment of any significant osseous lesions. To help predict outcomes and guide patient counseling, the Instability Severity Index Score, or ISIS, developed by Balg and Boileau in 2007 and later validated by Lopini et al. In 2019, is a valuable predictive tool, specifically for predicting recurrence after arthroscopic Bankart repairs.
Okay, so it helps decide if Bankart is enough. How does the ISIS score correlate with recurrence, and how do you use that in your discussions with patients about their prognosis?
The ISIS score is a 10-point system, incorporating factors like age, activity level, sport type, shoulder hyperlaxity, and the presence of Hill sacks and glenoid lesions. Higher scores indicate a greater predicted risk of recurrence after an isolated arthroscopic Bankart repair.
Right.
For patients with only 1 to 2 risk factors, corresponding to an ISIS score of 3 or less, the 5-year recurrence-free rate after arthroscopic Bankart is excellent, reported around 94%. These are generally the ideal candidates for that procedure.
Okay, low score, good outcome with Bankart.
Yes. With an ISIS score of 4 to 6 points, the recurrence-free rate drops to about 85%, which signals a need for caution and perhaps more extensive discussion about expectations or alternative procedures. However, for patients with an ISIS score greater than 6 points, the recurrence-free rate after arthroscopic Bankart alone is significantly lower, potentially down to just 55% at 5 years.
55%. That's almost half recurring.
Exactly. This lower rate strongly suggests that open surgical approaches involving bone augmentation, like the Latarjet procedure, should be strongly considered as a primary intervention for these high-risk patients, rather than relying solely on arthroscopic soft tissue repair. The ISIS score empowers us to have very precise, evidence-based discussions with patients about their individual prognosis, managing expectations realistically and helping them make informed decisions about their surgical path. For someone like Tom, calculating his ISIS score would be a key part of the preoperative planning.
That's incredibly useful for shared decision-making. So even with modern surgical techniques, meticulous rehab, and tools like the ISIS score, complications can still arise. What are the most common challenges we need to be vigilant about postoperatively, and how do we mitigate those risks for our patients?
Yes, unfortunately, complications can still occur. Redislocation or recurrent instability remains the main complication following anterior shoulder stabilization surgery. The risk is highest if there's significant unaddressed or underaddressed bone loss, that critical 20–25% glenoid defect, or an engaging Hill sacks, or perhaps insufficient fixation, such as using too few anchors during a Bankart repair. The risk is also significantly higher in younger patients under 20. Males, those participating in contact sports, and individuals with underlying hyperlaxity. While arthroscopic recurrence rates can range widely depending on patient selection and technique, anywhere from 4% to perhaps up to 20% or higher in some complex series, open procedures like Latarjet generally have lower recurrence rates, often cited in the 2–9% range. However, it's worth noting that a 2017 multicenter study found no significant difference in revision surgery rates between open and arthroscopic Bankart repairs in appropriately selected patients without significant bone loss, suggesting comparable efficacy when used for the right indications.
Okay, recurrence is the main one. What else?
Nerve injuries are another potential complication, though thankfully generally rare. The axillary nerve is the most commonly affected, typically presenting as a transient neuropraxia, a temporary nerve bruise. Its proximity to the inferior capsule, especially around the 5-6 o'clock position on the glenoid, makes it vulnerable during suture passage or anchor placement in the anteroinferior aspects. We are meticulously careful about identifying safe zones and protecting it.
Right.
A musculocutaneous nerve can also be at risk, particularly with procedures like the Letarjet, where it runs near the coracoid process being transferred. Careful dissection and identification are key. While infection is a concern with any surgery, there appears to be no significant difference in infection rates between open and arthroscopic Bankart repairs, with overall rates being quite low, typically well under 1%.
Okay. Implants. Stiffness.
Implant-related problems, historically a bigger issue with older devices like metallic staples or early bioabsorbable tacks, which could cause synovitis inflammation, are now much lower, maybe around 0.3%, with modern all-suture or peak suture anchor only devices. Stiffness, especially loss of external rotation, can occur, particularly after procedures like Letarjet or remplissage, which intentionally restrict some motion, or if the capsule is inadvertently over-tightened during a Bankart repair. This underscores the need for precise capsule tensioning and careful progressive rehabilitation. Over-tightening can potentially lead to post-capsular arthropathy long-term. Graft lysis, or resorption, can also occur with Letarjet grafts, with studies showing up to 90% undergoing some degree of radiological resorption within 6 months, though interestingly, this often doesn't seem to affect the good clinical outcome or stability rates. And as we discussed earlier, dislocation arthropathy long-term degenerative changes leading to glenohumeral arthritis remains a potential lead complication, highlighting again why our initial management, especially for young patients like Tom, needs to be so robust and aimed at restoring normal anatomy and stability.
That's a comprehensive look at the risks and how to manage them. Finally, beyond the acute treatment and rehabilitation phase, what proactive measures can we as professionals advocate for in terms of prevention, particularly in the at-risk athletic population? And how important is a truly multidisciplinary team approach in the overall management pathway?
Prevention is multifaceted and absolutely critical, especially for young athletes before they even have an injury or after one to prevent recurrence. Education and awareness are paramount. We must educate patients, their families, coaches, particularly adolescents, about the natural history of shoulder instability if left untreated or undertreated. This includes teaching proper mechanics for their sport, emphasizing the importance of maintaining strength and flexibility around the shoulder girdle, and crucially, recognizing early warning signs of instability or subtle symptoms before a major event occurs. For any patient under the age of 20 who experiences even one significant instability event, referral to a sports medicine specialist or orthopedic surgeon for comprehensive assessment and management is strongly recommended rather than just passive observation or minimal treatment.
Early referral is key for the young ones.
Absolutely. Strength training forms another key pillar of prevention and rehabilitation. Organized strength and conditioning programs throughout a sports season have been shown to significantly reduce the risk of acute injuries like shoulder instability. These programs should target all the key muscle groups, the deltoids, trapezius, rhomboids, teres major minor, and the entire rotator cuff supraspinatus, infraspinatus, subscapularis, along with the biceps and triceps. Isotonic exercises using weights or resistance bands and closed chain exercises like push-ups are particularly beneficial for promoting scapular stabilization and improving overall shoulder function, ensuring that dynamic stabilizers are robust enough to protect the joint.
Comprehensive strengthening.
Yes, and complementing strength training are proper warm-up techniques. A comprehensive 8 to 12-minute dynamic warm-up before practices and games, incorporating exercises like arm circles, crossbody stretches, and resistance band pull-aparts, is vital for enhancing blood flow, activating muscles, and improving mobility, thereby reducing the likelihood of injury during sudden movements.
Okay. And the team approach.
Finally, it's crucial to emphasize the interprofessional team approach. Optimal management of shoulder instability, particularly in athletes, truly requires coordinated care. This involves a collaborative effort from athletic trainers for acute sideline management and initial rehab bridging, primary care physicians including sports medicine specialists, mid-level practitioners, orthopedic surgeons, and nurses with orthopedic training. Physical therapists are absolutely indispensable for guiding the long-term rehabilitation, providing continuous feedback to the rest of the team, and adapting protocols based on patient progress and compliance. Seamless communication, verbal and written, and accurate, up-to-date documentation among all team members are essential to ensure the best possible patient outcomes and to adapt treatment regimens effectively. This holistic approach ensures every aspect of the patient's journey, from initial injury through surgery, recovery, and prevention of future issues, is managed effectively.
So wrapping this up, what does this all mean? Our deep dive today really highlights that managing anterior shoulder instability is, well, it's a multifaceted challenge, isn't it? It demands a really comprehensive understanding, from precise diagnosis through to meticulous surgical planning, tailored rehabilitation, and crucially, long-term prevention strategies. It's about taking a holistic view, tailoring every decision to each unique patient, considering everything from their activity level, their specific sport, their age, their expectations, down to the intricate bony and soft tissue lesions we identify on imaging and in the operating theater. It's truly a testament to how far orthopedic science and surgical techniques have advanced.
It really is. And this raises an important question for all of us moving forward. As our diagnostic capabilities become ever more precise with advanced imaging and arthroscopy, and our surgical techniques increasingly sophisticated and targeted, how might we further personalize treatment pathways? How can we move beyond just restoring immediate stability to truly optimizing long-term joint health and proactively preventing that silent progression of arthropathy in these highly active individuals, ensuring they can lead full, functional lives for decades to come?
A compelling question indeed, and one we must continue to explore in our practice and research. If you found this deep dive valuable for your practice, please do consider rating and sharing it to help us reach more professionals in our field. Thank you for joining us on the deep dive. We look forward to exploring more critical topics with you next time.